one of the reasons that I wanted to talk to you so much is because I think midwives are the most important a person to a woman when she's beginning her pregnancy. You are the people who she will bring her problems to. She will talk to you about drugs in breast milk, where she may not talk to anybody else just because you're more approachable, you're having that individual face-to-face meeting. I've always hated over the years when people have messaged me or in the early days phoned me up and said, this lady is in the delivery suite. We think she'll be about another 2 hours. Can you tell us whether she can breastfeed on the medication that she's been on? Or she delivered an hour ago, but we don't know whether we can put the baby to the breast. And that precious time has been lost. So as well as being a pharmacist, I'm also a grandma to 7, all of whom were breastfed, and took some persuading to stop in the majority of cases. So we know just the act of breastfeeding stops some women from taking medication. So even if they've got a headache, they'll go and have a drink or a walk rather than taking even the simplest of painkillers, compared to their colleagues who have chosen to formula feed. And this is about trying to preserve breast milk as being the purest gold dust that we want to give to our babies. My PhD research found that over 50% of women had some kind of medication in the first 5 days after delivery. And unsurprisingly, most of those were analgesics and antibiotics. Just an interesting find. I actually suspect that it's probably more than that, 50%. I think it's probably more like about 80% at least. But I entitled this Breastfeeding Medication, Can They Go Together? And I always see there being an issue about risk when we're putting the two things together. And we always want to be very cautious, and we want to keep both parties in this breastfeeding dyad safe. And we're thinking about protecting the baby who is going to receive some of the drugs through breast milk. And the default seems to be it's probably safer if you bottle feed, having forgotten all of the wondrous things that breast milk does. And until recently, the BNF was really just a tool of the pharmaceutical industry, saying things like the amount in breast milk, the amount of drug passing through breast milk is very small, but the manufacturers advise avoid. Well, why do they advise avoid? And it's just because they don't have to take responsibility. Even if a drug has been marketed for 40 or 50 years, it will still say, don't take if you're breastfeeding. I have a look at packets of ibuprofen. My undergraduate training was looking at how ibuprofen worked, and that was back in the 1970s. I think we know a lot about ibuprofen, but that's still on all the leaflets. So tonight, I'm going to give you a whistle-stop tour about how drugs get into breast milk so that you can help a mum make a decision and you can understand some of the things I've written in fact sheets. And the reason the fact sheets are written is just to save you time. So most drugs just diffuse from the blood into the milk through the cells. Do you remember it's sort of A-level, it might even be O-level science, where you have a membrane and you have a purple solution one side and it goes through the other side until it causes an equilibrium? And that's the same as how drugs pass into breast milk, except in the first few days after delivery, when there are these large gaps between the cell membranes to allow all the immunoglobulins to pass in to protect the baby. But within a couple of days, these gaps have closed up. And now the drug has to go across the cell to enable it to pass into breast milk. But we give the majority of our drugs in those first few days. But that's kind of reassuring because At that time, the baby's in the midwifery unit. This is custom and practice. We're used to doing this. And everybody has a very, very different view compared to when the baby is 3 months, 6 months, 3 years old, when everybody seems to be much more reticent to discuss safety of drugs in breast milk. Drugs can accumulate in breast milk if they have a long half-life. Now, as a quick refresher, the half-life is the time that it takes for 50% of the drug to be metabolized. And after 5 half-lives, we assume that it's all gone from the body. But if the half-life is more than 24 hours, after 24 hours, we maybe have 85% left, and then we have another dose, we've got 185%. And after day 2, then we've got a portion of the first days, a portion of the second days, and then we give another 100%. So it starts to reach a toxic level. And this is one of the reasons why giving fluconazole early after delivery worries me. When we wrote the thrush leaflet a few years ago, it seemed like every baby who causes mum nipple pain must have thrush. And we were giving out fluconazole willy-nilly. But we started to see babies being violently sick, really bad tummy pains. And it was because this level was accumulating. I actually knew of one baby that was about to have surgery, thinking there was trouble with the pyloric sphincter. And it actually was just the level of fluconazole that was passing through. If we have a drug with a large molecular weight, it's too large to get into breast milk at all. It's like trying to put a Lego brick through a sieve. It's just not going to go through the holes. And these are drugs which are usually given only by injection. So they are things like gentamicin, teicoplanin, insulin, but also the biological drugs. And if they can't be absorbed from the gut, it actually doesn't matter how much gets into breast milk. The baby can't absorb it from breast milk because it still has to have the oral bioavailability there as well. So, we will give the mum teicoplanin. Let's say she has a severe infection. Doesn't matter, the baby's not going to get any. But as I've already said, the BNF is not giving us much information about how to make informed choices. It doesn't give us any differentiation about whether the advice is different, whether it's a newborn or a preterm or a toddler or even an older child. I actually saw a discussion this week where a 7-year-old was still breastfeeding. The amount of breast milk that 7-year-old was likely to be getting was very, very small. So whatever the mum was going to take wouldn't be getting through. The anti-TNF drugs, the biological drugs, are becoming much more widely used with chronic conditions like Crohn's disease, rheumatoid arthritis. But everybody gets really concerned about the toxicity of these drugs, whether they are going to reduce the immunity of the baby, and if breast milk then has any benefits, because we're taking away all the goodness. I'm very interested in these because I have Crohn's disease myself. I actually haven't had to take an anti-TNF drug yet, though it keeps being threatened. The only things with the anti-TNF drugs is that the baby can't receive live vaccines for the first 6 months of its life. So it means that we need to omit the rotavirus from the vaccination schedule. And as much as the baby being immunocompromised by the amount of drug passing through in utero, the live virus is shed in fecal particles for 2 weeks after the vaccination, and the mother may pick them up in that time. So she either has to use rubber gloves when changing the baby's nappy for 2 weeks, be really, really careful with hand hygiene, or we just admit it. But exclusively breastfed babies very rarely have rotavirus anyway, so it's not such an issue. A lot of these drugs for which we use anti-TNFs are autoimmune diseases, which are influenced at least in part by the way we're breastfed as infants. So a lot of people who have these ones will have been formula fed in the past. And that's what we've been fighting for the last 30 years. Most babies will have had some formula milk, particularly in those first few days. And we're breaking down their guts and allowing these foreign proteins to come through. So any mum who's got one of these acute conditions will do everything in her power to protect her baby. None of us want any harm to come to our babies. I'm found in much of the literature, it talks about the half-life and timing of drugs in order to minimize the amount that gets through in breast milk. So that mums are told things like, feed immediately before you take the tablets and then don't feed for 6 hours afterwards. Well, if you've got a young baby, that's an absolute impossibility. And it's actually completely irrelevant, because any drug that you take for more than 5 half-lives again will have reached a peak which will stay there all of the time. You'll get slight peaks and troughs, but it pretty much reaches a steady state. So I've had things like mums told to avoid sertraline, avoid breastfeeding after they've taken sertraline for 4 to 5 hours. Now, they will then try and take it before their longest sleep. And they'll usually take it at night time, assuming the baby is going to sleep longer at night time. And we know they very much don't do that. But what if the baby does normally sleep for 4 hours, but on this time it's teething and wakes unexpectedly? Is she going to breastfeed? Is she going to try and stop the baby from feeding for longer? This is just going to add to her anxiety and depression for absolutely no reason at all. So the only reason that we would try and time feeds is in an acute medical situation, but not in a chronic situation. The relative infant dose is probably one of the most useful pieces of information. It doesn't appear in the BNF, it only occurs in specialist sources. And the relative infant dose of less than 10% is considered compatible with breastfeeding. It was first introduced back in 1996, but has been widely used by Hale. But we can't use it just by itself. We need the full picture, because things like methotrexate have a very low relative infant dose. But if we're using them continuously to treat rheumatoid arthritis, it's not compatible with breastfeeding. Mums with perinatal mental health were asked what do they want professionals to know about how their mental health challenges could be assisted or made worse. And the thing they came back with was saying stopping breastfeeding can make things worse. Whereas actually, too many times we're told that the pressure to breastfeed, which is what causes the perinatal mental health problems. And if you've got a professional then saying, well, you could take this, but some of it will get through to your baby, it can be very scary. When you stop breastfeeding, you can actually have an increase in depression and anxiety because you're losing the oxytocin benefits, which is helping you to relax, sleep more deeply, faster. So the most important thing, I think, is that women should be involved in the discussions about whether they can breastfeed or not. They should be given information in a manner which they can understand, and actually about how much is going to get into breast milk, rather than being told, you must stop breastfeeding because the BNF says that there's no information, or the manufacturers advise avoid. There's actually much more information around out there than the BNF is going to provide for us. And having a medication is part of their choice. If they believe very strongly that breastfeeding is part of their way of mothering, telling them to stop can be very detrimental. So very quickly, a few of the situations that you may come across, and I'm sorry if it feels like this, I'm teaching my grandmothers to suck eggs. I can't think of any antibiotic that a breastfeeding mum can't take. We always used to think that metronidazole affected the taste of breast milk, and that's come down through history. But I can't find where this originated. And I've wondered whether it was because the original manufacturers of metronidazole, it was under the brand name of Fragile, and it was bright yellow. And I wonder if some of the bright yellow colour came through and somebody looked at it and go, ugh, that doesn't look very nice. I bet it tastes horrible. But toddlers have said that actually, if you eat foods rich in garlic, it masks the taste of anything. So if you've got a mum who's taking metronidazole, tell mum to go and have a nice spag bowl with plenty of garlic in, and there won't be taste of any drugs in there. Amoxiclav and erythromycin seem to cause more stomach pains and more vomiting in babies. Don't really know why. It is just happens. But if mums know that this is going to happen, at least they're warned that the baby isn't having some strange reaction that they need to seek medical attention. And remember to remind mum that she's passing on antibodies and that she can't transfer her infection through breast milk. The social media forums are full of, if I'm breastfeeding, I'll pass COVID to my baby through my breast milk. No, you won't. You may pass COVID because you sneeze over your baby or you cough over your baby, but you're not getting it through breast milk. And most breastfed babies caught COVID in such a mild manner that they didn't care. Their mums might have been feeling poorly, but they weren't. We've often used labetalol because we use it antenatally, but you need to be alert for white nipples after a feed because labetalol cuts off the blood supply to extremities. So you might notice these very white nipples, in which case it's not the drug for her. If you're going to use an ACE inhibitor, which would always be my drug of choice, use enalapril because it's got the most evidence behind it, and we give it to children. And this relative overdose is so far below 10%. We use nifedipine for Raynaud's phenomenon, which I seem to have seen a lot of this winter. But we want to avoid diuretics because they're going to decrease the fluid that's in the mum's body and may lower her milk supply. Pain relief is part of your daily business. The MHRA are still recommending that we shouldn't use codeine during breastfeeding because of the changes in maternal metabolism. But if she's taken an accidental dose because her husband has brought her 2 painkillers and actually they were cocodamol rather than paracetamol, it doesn't mean she has to stop. One-off dose isn't going to do any harm. The opioid of choice is dihydrocodeine or oral morphine because both of them have substantial first-pass metabolism. And remember, particularly if they've got hemorrhoids, they can have laxatives too. The laxatives don't get into breast milk. Stool softeners do that, just soften the stools, which I always remember the 4th stage of labour as being far more painful than the 1st stage of labour. So reassure them that they can have a laxative if they need to. And remember, as Claire said, sometimes babies refuse to take a bottle. And if we suddenly tell a mum to stop breastfeeding, she may risk mastitis. The baby may become intolerant of cow's milk protein with just a few things. So trying to do no harm, we may actually cause more harm. And the mum may have to re-stimulate her milk supply afterwards. The resources you'll have a list of as well. I have to say, my books, as I say, they don't make a lot of money, but they became grandma's boasting books because both those are my daughters and grandchildren on the front of them. Very whistle stop. I could go on for hours, but if you need to answer me a question, I'm never very far away. So you can email me or contact me via the Facebook page. I'm there to try and help you help mums. And thank you for all you do.